Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I've been feeling uneasy with the pins and needles sensation in my legs for a while now. It's there almost every day and seems to get worse at night. Initially, I thought it might just go away, but it's been persistent. About 3 weeks ago, I also had this strange episode while watching TV. My chest felt tight and I started sweating a lot. It was over in about 6 to 8 minutes, but it scared me.
I understand that must have been quite worrying for you. Can you tell me more about the transient weakness and numbness in your arms and legs that you mentioned?
Yeah, that happened a few months back. It was all of a sudden. Both my arms and legs felt weak, and there was a tingling sensation, almost like they weren't there. I had to strip down because I felt unbearably hot, though the room wasn't warm. It went away on its own after a while, but it was an unsettling experience.
Have you noticed any specific triggers for these episodes or any pattern?
Not really. They seem to come out of nowhere. There's no particular time of day or activity that triggers them. As for my legs, the tingling gets worse at night when I'm trying to sleep.
Let's talk a bit about your smoking and marijuana use. How has the smoking cessation effort been going?
I've been trying to cut down. It's tough, though. I'm down to about half a pack a day from a full pack. The marijuana I still use regularly, twice a day. It helps me relax, I think.
And you've mentioned you've been diagnosed with prostate cancer. How do you feel about the information you've received regarding your diagnosis and treatment options?
To be honest, I'm quite confused and a bit anxious. I know I have prostate cancer, but my doctor at All Care hasn't gone into much detail about what to expect or the treatment plans. I'm thinking of maybe transferring to a more specialized center, but I don't want to lose the continuity of care I have at All Care since it's close to home.
That makes sense. It's important that you feel supported and informed about your health decisions. Have you had any significant urinary symptoms or changes since your diagnosis?
No, not really. No trouble urinating or anything like that. It's mostly the fear of what might happen next that bothers me.
I appreciate you sharing these concerns with me. Let me summarize your main issues. The persistent neuropathic symptoms in your legs, the episode of chest pain, your prostate cancer, and your history of substance use. I also took note of your recent lab results and imaging tests. Here's what we see. Your PSA level is slightly elevated at 5.2 n-grams per milliliter, which is consistent with your diagnosis of prostate cancer. Your thyroid function is normal, and your iron levels and blood counts are within normal limits.
So, what do we do next? I'm really concerned about all these symptoms and my prostate health.
Firstly, regarding your neuropathic symptoms, we should perform additional diagnostic tests to pinpoint the cause. This could include nerve conduction studies to evaluate the extent and nature of the neuropathy. For your prostate cancer, I recommend a consultation with a urologist who specializes in oncology. They can provide more detailed information about potential treatments like surgery, radiation, or medications.
And what about the chest pain episode?
Given the nature of the episode, it's essential to rule out any cardiac issues, even though your ECG and chest X-ray didn't show abnormalities. I would suggest a stress test to assess your heart's function under exertion. It's also important for you to seek immediate medical attention if you experience another episode like this.
Thank you for clarifying these steps. It helps to have a plan moving forward.
Absolutely, I'm here to support you through this. We'll schedule the nerve conduction study and the stress test as soon as possible. I'll also refer you to the urology-oncology specialist and ensure they receive all your medical records for a comprehensive review. It's important that you continue with your efforts to quit smoking, as this will significantly benefit your overall health.
I'll try my best. Thank you for all the information and for listening to my concerns today.
You're welcome. It's important that you feel supported and informed. We'll follow up on all these actions, and I'll see you back here after your tests, or sooner, if you have any more episodes or concerns.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been struggling quite a bit lately. The pain in my right knee has been there for years because of the osteoarthritis, but now my ankle and toe are making it even worse. And this isn't the first time. These flare-ups have been happening more frequently. Just yesterday, the swelling in my ankle had me hobbling all day.
I understand that must be really difficult. How long have you been experiencing these flare-ups?
It's been ongoing, but these past few weeks have been particularly bad. Ever since my surgery last month, it seems like everything's just been more intense. The gout has definitely gotten worse. I try to stick to the diet we talked about, but sometimes it's hard.
Surgery can often trigger gout flare-ups due to the stress it puts on your body. Let's make sure we address that as well. How has your walking been affected by this?
It's been tough. I can barely manage short walks. My knee, and now my ankle, it feels like each step is a gamble on whether I'll have a sharp pain or just the usual ache. I used to at least manage to get around the block.
That must be incredibly frustrating for you. And you mentioned earlier a recent viral infection as well.
Yes, that was about 2 weeks ago. It started off as just a cold, but then it hit me hard because of my asthma. I ended up in the hospital because I couldn't breathe well. We had to increase my asthma medication during that time. Thankfully, I'm breathing easier now, but I still feel wiped out.
Recovery can certainly take a toll, especially with multiple health issues at play. You mentioned being on prednisone. How are you finding it?
The prednisone helps with the swelling, but the side effects aren't great. I feel more jittery and restless. I'm also worried it's affecting my sleep.
Prednisone is effective, but it can have those side effects. It's good you've mentioned this. Managing the side effects is part of tailoring your treatment. How about your daily activities? How are you managing at home?
It's been hard. I'm moving slower, and sometimes I need help with things I used to do on my own. My energy levels just aren't what they used to be, and I've had to ask my family for more help.
It's important to have support, so I'm glad to hear your family can be there for you. We'll look at ways to manage your pain without overly relying on medications like hydrocodone, which I see you need a refill for. Have you been taking it regularly?
Yes, mostly at night. It helps me sleep through the pain, but I don't want to keep increasing the dose. I'm worried about getting too dependent on it.
That's a valid concern, and we'll consider that in your treatment plan. Now, based on today's assessment and your recent tests, let me go over the key points and our next steps.
Please, I need something that can really help with all of this.
Firstly, your blood pressure and heart rate are stable, which is good. However, your recent labs show your uric acid levels are elevated, which is likely contributing to your gout flare-ups. We'll start allopurinol from May 10th to manage this long term. Your kidney function tests are slightly off with a creatinine of -2 and BUN of 28, likely due to your chronic kidney disease. We need to monitor this closely, especially with the medications you're on. For your arthritis and gout, continuing prednisone for now is necessary, but we'll adjust the dose as planned. The Lasix will help manage your swelling, and we'll keep it at 20 milligrams. I'm also going to refer you to a podiatrist for your foot issues and a rheumatologist for ongoing management of your gout and arthritis.
Okay, what about the pain and my mobility issues?
The referral to podiatry will help address your structural foot issues, which might be contributing to your mobility problems. For pain, besides hydrocodone, I would like to explore non-medication options like physical therapy, which can help improve your strength and flexibility without increasing medication reliance. Lastly, it's crucial you keep monitoring your symptoms, particularly any new pain or swelling. Make sure you follow up with rheumatology and podiatry as scheduled and see me in 5 weeks to review everything. Any questions?
No, that covers everything. Thanks for helping me sort through all this, doctor.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Today, we are discussing an important issue, managing patients who lack insurance. This challenge impacts patient outcomes and our healthcare operations.
Absolutely. A key strategy is implementing a sliding scale payment system. This approach adjusts charges based on the patient's ability to pay, ensuring that financial constraints don't hinder access to care.
Another essential component is establishing partnerships with charitable organizations and securing grants. These partnerships can provide funding to cover costs for uninsured patients, allowing us to deliver necessary treatments without financial barriers.
We also emphasize preventive care and education. By focusing on prevention, we reduce the need for more expensive emergency care, which is often where costs accumulate fastest for uninsured individuals.
Indeed. And let's not overlook the importance of patient advocacy. Our social workers play a critical role in helping uninsured patients navigate available resources and government aid programs.
To conclude, managing patients without insurance requires a multifaceted approach, incorporating financial, preventive, and advocacy strategies to ensure comprehensive care.
Now look at question 26.
I appreciate your concern as a family member. Let's discuss the available treatment options for your loved one.
Thank you, doctor. What are we looking at in terms of treatment?
Given the diagnosis, there are several routes we can take. The first option is medication, which can manage symptoms effectively. Another option is surgery, which might be considered if medications don't achieve the desired results.
How do these options impact his recovery long term?
Medications can control symptoms well and are less invasive, which means quicker recovery times. However, if we opt for surgery, the recovery might be longer, but could potentially resolve the underlying issue permanently.
I see. It's important to balance effectiveness and recovery. I'll discuss these options with the family.
Now look at question 27.
Let's focus on enhancing our dementia care plan. The goal is to improve patient safety and the quality of care across our facility.
Agreed. We should start by training our staff on dementia-specific care techniques. Understanding the unique needs of these patients is crucial.
Integrating technology can also play a significant role. For instance, using electronic tagging systems to ensure patient safety and prevent wandering.
And what about the therapeutic environment? Creating spaces that reduce confusion and promote calm can make a significant difference in their comfort and reduce agitation.
Yes, let's also establish a protocol for involving families more in the care process, providing them with support and education to help manage their expectations and involvement.
These initiatives can dramatically improve our dementia care services. Let's draft a revised plan incorporating these ideas and review it in our next meeting.
Now look at question 28.
I'm here to help you manage your COPD. Let's discuss your current treatment plan and any difficulties you're experiencing.
Thank you. Lately, I've been struggling more with shortness of breath, and it's been hard keeping up with my daily activities.
It sounds like we might need to adjust your inhaler usage. Have you been using it as prescribed?
I try to, but sometimes I forget, and I'm not sure it's helping much anymore.
Consistency is key with COPD management. Let's explore a reminder system to help you take your medication on time. Additionally, we might consider a different type of medication that could be more effective for you.
That would be great. I want to feel better and get back to doing more around the house.
We'll work together on this. I'll also recommend some breathing exercises that can improve lung function and decrease symptoms.
Now look at question 29.
Your recent lab results show a decrease in renal function, which affects how your body handles medication. We need to adjust your dosages accordingly.
Does this mean my medications will be less effective now?
Not necessarily. It means we adjust the dosages to ensure effectiveness while minimizing potential side effects. This is crucial to avoid over-medication and further complications.
I understand. How often will we need to check my kidney function?
We should test your renal function every 3 months to monitor any changes. Based on those results, we might adjust your medication further.
Okay, that sounds good. I appreciate you looking out for these issues and explaining everything clearly.
Now look at question 30.
Today's presentation focuses on promoting blood sugar level monitoring in the workplace. This initiative can greatly benefit our employees with diabetes or prediabetes.
That's a great initiative. Regular monitoring can help employees manage their blood sugar levels and reduce the risk of diabetes-related complications.
Exactly. We plan to provide training on how to use glucose meters and interpret the results. Knowledge is power, and we want all employees to feel empowered about their health.
Will the company also offer support for those identified with high blood sugar levels?
Yes, we'll have a system in place for referrals to healthcare providers and provide ongoing support through our wellness programs. It's all about creating a healthier workplace environment.
This proactive approach is excellent. It not only helps individual employees, but also enhances overall productivity by reducing health-related downtime.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Yeah, I think that's a really good teaching point, that we need to think of these drugs in a slightly different way in terms of whether we're stopping them or restarting them. I think every patient is different in terms of their risk of clot formation and bleeding, and the guidelines set out in Table 1 the subgroups of patients at particular risk of thrombus formation. Can you tell us more about those patient populations?
Sure. Now, when as a clinician I'm seeing a patient for perioperative management, what anchors my assessment is an empirical but patient-centric evaluation of what I think is their thromboembolic risk and what I think is their bleeding risk. The former is driven by a number of factors. Whether a patient has a mechanical heart valve, for example, a mitral valve is higher risk than an aortic valve. Whether they have atrial fibrillation, a very high CHADS-2 or C8-2DS2-VASI score is higher risk than a low CHADS-2 score. And whether they have venous thromboembolism, VTE, higher risk is whether the episode occurred, let's say, a pulmonary embolism within a month, or is more remote. The bleeding risk is driven largely by the surgery or procedure, not due to as many patient factors. These two elements anchor how we manage patients, whether we need to interrupt anticoagulants, and if so, how do we manage? When do we interrupt? If we interrupt a vitamin K antagonist, do we need to bridge? I need to point out, and this is a very important point, that these risk assessment formulations are empirical. They have not been validated prospectively, but we developed them to allow clinicians to have a starting point to assess risk for thromboembolism and bleeding, and they have to be used in conjunction with clinical judgment. Let me give you an example of what I mean. Let's say I had a patient with atrial fibrillation who needed elective surgery on a direct oral anticoagulant, and they had a C8-2DS2-VASI score of 3. But let's say that C8-2DS2-VASI score included a prior stroke that occurred perioperatively, and their other factor is hypertension. Although the risk formulation may consider those as low to moderate risk, in fact, you might consider that patient higher risk because they had a perioperative stroke. The table is there to provide a starting point to assess patient risk, but your clinical judgment has to be combined with individual patient characteristics and guidelines. For instance, consider the patient's overall health status, including factors like age, renal function, and any comorbidities that might affect their response to anticoagulation therapy. A patient with compromised renal function may require a different approach to direct oral anticoagulant management compared to someone with normal renal function. Additionally, consider the type and urgency of the surgery. Certain high-risk surgeries may necessitate a more cautious approach to anticoagulant interruption and resumption. Also, the patient's previous history of bleeding or thrombotic events should weigh heavily in the decision-making process. For example, a history of gastrointestinal bleeding might prompt more conservative management of anticoagulants. Furthermore, patient preferences and values play a crucial role. Discussing the risks and benefits with the patient to understand their perspective and ensure informed decision-making is vital. This holistic approach ensures that the management plan is tailored to the individual, optimizing outcomes by balancing the risks of thromboembolism and bleeding in the context of the planned surgical intervention.
I think, applying guidelines rigidly to every patient you see is obviously not a good idea, but this guideline is a very useful resource to residents if they have questions in terms of perioperative management. So I think that's a good understanding of patient factors, procedural risk, and the metabolism of these drugs. Let's move on to a practical example. Let's start with warfarin. I think the guideline recommends stopping for at least 5 days for anything other than minimal bleeding risk. What do the guidelines recommend regarding vitamin K if the INR is still high preoperatively?
There still are a lot of patients who are receiving warfarin nowadays, not just for mechanical heart valves, but also for atrial fibrillation worldwide. It's something that we'll continue to see until they are replaced entirely by other agents. In the area of warfarin interruption, our recommendation is at least 5 days of interruption. The only caveat there is that you may require an extra day or two in selected patients, let's say, who have a higher target INR if they have a mechanical heart valve, or in some patients that, because of age or other drug interactions, may metabolize the warfarin less quickly. So once again, part of that individualized management. In regard to the vitamin K, it might seem counterintuitive to listeners. Why would you not give vitamin K if you did an INR and it was over 1.5? Well, the reason is that when we looked at the evidence, our recommendations are anchored on the actual evidence. The data are not very good to support the use of vitamin K because these are observational studies, and the efficacy to reduce the INR was not sort of robust or uniform. The other part is that patients don't routinely get INRs before surgery, and we don't advocate for that because there are a number of studies that forego doing an INR the day of the surgery, as long as you have that at least 5-day window of warfarin interruption. Rates of major bleeding are quite low, so it doesn't appear to affect clinically meaningful outcomes. The other part was a practical part that we mentioned, that vitamin K may not be easily available in an oral form. It sometimes can be given intravenously, which we don't want to recommend routinely, and may lead to warfarin reinitiation resistance. For those reasons, we did not recommend the routine administration of vitamin K for more patients who had a higher INR over 1.5. Of course, this does not exclude you from doing that. If, let's say, a patient unexpectedly has an INR of, let's say, 2 or 2.5. Of course, you're going to give vitamin K to allow that surgery to proceed within the next day or so.
You mentioned prosthetic valves at the start of your answer. I think a lot of people would like to hear from you, given the recommendation in the guideline about mechanical valves. Maybe you could tell us a bit about the thinking behind that.
Sure. This is one of the controversial areas that might raise a bit of eyebrows among readers or listeners. In our guideline recommendations, we actually suggest against bridging in patients with atrial fibrillation. This is a moderate strength of evidence. Also against bridging in patients with venous thromboembolism, and perhaps unexpectedly in patients with a mechanical heart valve. Of course, all of whom, these 3 groups, would be receiving warfarin. But we go on to say the following. We're starting out with the premise that the default should be not to bridge. And the rationale for that is if you look at the totality of evidence, whether it is in any of these 3 groups, but particularly in patients with atrial fibrillation, we found that the evidence does not support bridging as a way of mitigating against the risk of perioperative arterial thromboembolism. But there is consistent evidence that it increases the risk for bleeding. You don't want to have bleeding perioperatively, because that in turn may lead to further delay in the resumption of anticoagulation, which will have the undesired effect of exposing those patients to an increased risk of stroke and other thromboembolism. So we're starting with that premise, that the default is don't bridge. But we go on to provide additional recommendations that you can bridge patients who are deemed at high risk. So that's when you can apply the thromboembolic risk table to identify who might be some of these patients. So patients with a mechanical heart valve in the mitral position that have at least one risk factor, which is pretty well all mechanical mitral valve patients. Patients who have a very high CHADS score, or CH2DS2 VASC score. Patients who have had a recent, within 3 months, episode of venous thromboembolism. Those are patients that we actually advocate in favor of bridging, although that is a kind of conditional recommendation based on very weak evidence. And then we also go on to say, as I alluded to earlier, Riley, that clinical judgment plays a role. Just because somebody falls into that low-risk category by the table doesn't mean you cannot consider them at higher risk based on individualized factors. So yes, we're advocating against bridging, but with important caveats and qualifiers.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good morning, everyone. Today we will delve into the updated American Academy of Pediatrics AAP guidelines for the prevention and management of hyperbilirubinemia in newborns. This comprehensive update is critical for healthcare providers as it outlines evidence-based practices aimed at improving neonatal care and preventing severe outcomes such as kernicterus. To begin, let's discuss the guideline development process. The AAP updates its guidelines through committees composed of volunteer experts, often including members from previous guideline committees. These experts review current evidence and tweak previous recommendations accordingly. A significant update in the new guidelines is the recommendation for universal bilirubin screening for all infants, a move aimed at early detection and intervention. Historically, the 1994 guideline was AAP's first clinical practice guideline, laying the foundation for subsequent updates. The guidelines are reevaluated every 5 years to incorporate new research findings and clinical practices. This iterative process ensures that the guidelines remain relevant and effective in improving neonatal health outcomes. The prevention of hyperbilirubinemia starts with obstetric care. It is crucial to measure maternal blood type and conduct an antibody screen. For babies with positive maternal antibody screens, a direct anticoagulant test, DAT, should be performed to detect any potential risk of hemolytic disease. Special attention is necessary in cases where prenatal records are incomplete, as these infants may be at higher risk of developing severe hyperbilirubinemia. Universal bilirubin screening is now recommended for all newborns. This approach is particularly important for marginalized populations, such as infants with Down syndrome, who may have unique risk factors. Transcutaneous bilirubin measurements are generally reliable. However, they are not recommended during or within 24 hours after phototherapy due to potential inaccuracies. Phototherapy guidelines have also been updated. The new curves for initiating phototherapy are less conservative, which aims to reduce the number of unnecessary treatments. More intensive phototherapy is recommended to decrease the duration of treatment and hospital stay. It is essential to maintain and validate phototherapy equipment regularly to ensure its efficacy. Monitoring and follow-up are crucial components of managing hyperbilirubinemia. Bilirubin levels should be monitored regularly during phototherapy, starting 12 hours after initiation and continuing daily. Phototherapy should be discontinued when bilirubin levels drop 2 mg bilir below the phototherapy threshold. Follow-up should occur within a day after discharge, with additional bilirubin measurements considered based on the infant's risk factors. In cases of severe hyperbilirubinemia, escalation of care is necessary when bilirubin levels approach the exchange transfusion threshold. Immediate measures include aggressive phototherapy, adequate hydration, and preparation for potential exchange transfusion. Early consultation with a neonatologist is vital in these situations to ensure timely and appropriate interventions. Special considerations must be given to infants with G6PD deficiency, a significant risk factor for severe jaundice and kernicterus. Current challenges in rapid diagnostic testing for G6PD deficiency necessitate a cautious approach. Recommendations include avoiding fava beans and certain products that may exacerbate G6PD deficiency in newborns. Now let me illustrate these guidelines with a relevant case study. Baby J, a full-term infant, was born to a mother with an O+ blood type and positive antibody screen. During the initial assessment, a DAT-T was performed on baby J. Due to the maternal antibody screen results, the test came back positive, indicating a risk of hemolytic disease. On the second day of life, baby J underwent universal bilirubin screening, which revealed elevated bilirubin levels. Given the positive D8 and high bilirubin levels, intensive phototherapy was initiated immediately. Regular monitoring of bilirubin levels began 12 hours after the start of phototherapy and continued daily. The phototherapy equipment was maintained and validated to ensure its effectiveness. Baby J's bilirubin levels gradually decreased, and phototherapy was discontinued once the levels were 2 mg/L below the phototherapy threshold. Baby J was discharged with a follow-up appointment scheduled for the next day. During the follow-up, Baby J had a repeat bilirubin test, which showed stable levels. The healthcare team provided detailed communication and follow-up planning with Baby J's family, emphasizing the importance of monitoring and potential signs of jaundice. This case exemplifies the importance of the updated AAP guidelines in managing hyperbilirubinemia. By following these evidence-based recommendations, healthcare providers can effectively prevent severe outcomes and ensure timely interventions. The updated AAP guidelines aim to simplify care, reduce unnecessary treatments, and ensure timely intervention to prevent severe outcomes like kernicterus. Clinicians are empowered with evidence-based decision-making tools to provide optimal care for newborns, ensuring detailed communication and follow-up planning, utilizing shared decision-making with families, and being vigilant in monitoring at-risk infants are key aspects of these guidelines.